So, welcome everybody. The case I'd like to present to you here is what at first glance appears, a very complex aesthetic and occlusal case. But it's an interesting case because we're going to incorporate ceramics, resin bridge work, and so I think it's a nice case to look at those aspects as well. And this is a case that I presented recently when I did a day with myself down at the British Dental Association down in London. So let's have a look at the case and, let's look at first of all the aesthetics. Well, the aesthetics are poor. We've got worn incisors, spacing between the central incisors. On the right, we've got a peg-shaped lateral. On the left, we have no lateral, that's gone. And then lower arch, we've got the spacing and the wear, particularly down around the lower right 2 region. Gets worse, but if you look at the occlusion of the patient as well, she's got this deep overbite as well. So she's got a deep traumatic occlusion causing wear to the teeth, and then she's got these multiple restorative spaces. Okay, she's got spaces at the bottom, she's got spaces at the top. It's really a bit of a mess. And interestingly, when I saw her, the first thing I say is, well, look, really the first person you need to visit is the orthodontist. And the response I got back is that this is post-orthodontics. So this lady's already had 4 years of orthodontics. Unfortunately, she's going to need another 2 to 3 years of it again to get these teeth into a position where I can predictably restore them. You can't do much with this, okay? You could build up the midline diastem with BioClear. You could build up the upper right 2 with BioClear to some degree, disguising the 3 on the left as a lateral. It's very, very difficult and challenging to do this purely in composite. You could do it in ceramic, but you're going to have to end up doing a lot of tooth preparation to do this in ceramic predictably. But then it still leaves you with the problem that you've got this unfavorable traumatic bite. So whatever you do is going to be compromised. Whatever you do is going to fail early. And then you've still got a compromised bite. So it's a tricky case. But here's post-ortho. And, this wasn't 6 months of ortho. This is a more substantial ortho. But look what the orthodontics has done for us. In the lower arch, it's got rid of all the spacing. So really restoratively, a bit of reshaping of those lowers will be done. It's decompensated that deep traumatic overbite. And look, it's lined up the canines nicely. So whatever we do here is going to last because we have that protective canine guidance that is critical to longevity in these cases. We have fewer cosmetic issues now. We have a peg-shaped lateral on the right that we need to make look like a normal canine. But then we have the space on the left where we can actually restore that gap with something that will look like a lateral incisor. We do have some issues with the centrals. They still have some wear on there, and that could either be restored with some composite or it could be restored with just some reshaping would be quite reasonable as well. And so where are we going with this case? Well, we had the residual space up on the left, but you can see what the orthodontist has done for us is close all the other spaces. So that's reduced the restorative need for this patient by closing the spaces. Now, we couldn't do that top left, and you can remember from the first slide that we had a very, very compromised situation with pneumatization of the sinus. So what we've undertaken here is a sinus lift, implant placement, and an implant crown to restore that space there. Then what can we see that else we've done? You can see from the OPG that we've actually restored the lateral incisor from a peg shape to a full-size lateral. Now, cleverly, what we'd liaised with the orthodontist to do was leave some spacing, as you remember from the last slide. So this could either be done in ceramic or we could do in composite. And in this case, we did it with ceramic because all of the tooth prep had already been done for basically a 360 veneer to go on that tooth. And then finally on the left side, you can see that the orthodontist has left the roots very nicely for us for implant treatment. However, by the time we got to this stage, the patient had run out of money for implants. So what you'll see here is we actually went for an adhesive bridge in this area. So as with most of these cases, we are basically going to tooth whiten her first because she basically wants to just elevate the lightness of the teeth. And there you can see on the lateral, we could have done this in composite, we did this in ceramic, and you can see a very minimal all ceramic preparation still in enamel. And that allows us to deliver a highly aesthetic Emax restoration for her. On the left, because essentially we didn't go for the implant because she'd run out of money, we're going for an adhesive bridge. However, she's very challenging for an adhesive bridge. Look how thin those central incisors are. Now, if we went for a conventional metal bridge here with metal wings on it, we're going to get a horrible show through and grayness of those teeth. So in the final slide, I'll show you in a bit, but what we did with the central incisors was we built up the incisal edges with some Venus pearl. And within the Venus pearl, they have that blue tinge composite, which builds those up beautifully. And then we went for a zirconia bridge on the left-hand side. And some of you will look at that and go, double abutted. Yes, it's double abutted because it's post-ortho. So the beauty of double abutting post-ortho is that then is our retainer. It's like a retaining wire on those adjacent teeth. Because if we don't double abut, we've got an issue. If we cantilever off the canine, there's always a risk that that canine is going to do that. Likewise, if we distal abut off the lateral, off the central, that lateral may do that. And I've seen that happen a lot post-ortho. So generally, yeah, one wing would be preferable, but that is going to splint our teeth. Then we're going to put bonded wire on the 1, 2, 3 on the right, okay, extending that round to further back if we need to. But you can see palatally, you can see the beauty of the zirconia adhesive bridge is that essentially we can take it right up to the incisal edge, but you're going to get none of that horrible grey show through. The adhesive bridge is going to have a good longevity because the orthodontist has given us a beautiful protected occlusion. So I think this is a nice case because it kind of shows this synergy between orthodontics, which can help us in terms of aesthetics, and it can help us in terms of the occlusion. And then using modern ceramic techniques and implant dentistry to obtain a really lovely cosmetic result at the end of the day. So let's look in some detail at the final result. So if you look at where we started from, bad occlusion, deep traumatic occlusion, tooth wear, okay, it's really a case that it's only going to get worse. The orthodontics then sets us up with a good occlusion, but ideal spacing on the upper right too. So what we can do with the upper right too then is do our very minimal all ceramic 360, which gives us a lovely result. And then on the left hand side, we have the zirconia adhesive bridge. And don't forget, the few studies we've got on zirconia adhesive bridges show very, very good results in the incisor region. So we've got our zirconia adhesive bridge, which again gives us a lovely result, and again using an ovate pontic technique, scalloping out so we get that nice emergence up there. So we've got an Emax crown on the right, a zirconia adhesive bridge on the left, which gives us lovely aesthetics. The patient's whitening went very well, so that gives us the opportunity to lighten everything up for her to give her a nice brighter smile. And then following that as well, if you see that we have restored the incisal edges on those incisors, and that was done with the bluish tinge composite from the Venus Pearl range from Occlusal. So it's a nice kind of synergy of a number of techniques coming together. The lower incisors, you can see that we've just reshaped those and flattened those off. But I think one of the pleasing things with these cases is the occlusion that has been generated. So these restorations are going to have a very, very good longevity. So thank you for your attention today, and I hope that case provides some interesting points for you to look at there. So thank you very much.